assessment of case studies in selected countries, which included Morocco, Kenya, Ukraine, Vietnam, and Iran. There was then a synthesis of this data to develop a concise document which went under peer review and finalization. The tool is structured in a series of chapters. The first chapter sets the scene, gives a little bit of insight into what OAT is, some of the principles of OAT, and the rationale of providing additional tools to support scale-up. The second chapter provides insight into a suggested framework of how OAT services can be delivered and expanded, and we'll get a bit more detail on that in a minute. Chapters 3 to 7 are structured in relation to the different phases of a typical OAT program, and in each chapter there are specific sections that go into some of the details of how to provide these services. There are some standards which are provided early on, which countries and programs can aim to strive to meet to provide quality services. The 8th chapter gives some details into things to take into consideration to provide services to populations with specific needs, including women and also young people with opioid dependence. The case studies were drawn from the countries of focus. They were intended to show different aspects of OAT programs from Iran, Kenya, Morocco, Vietnam, and Ukraine. The various chapters are structured in relation to some how-to sections, and the intention was for this to be very practical, to provide guidance, and also to provide cross-references of where more detailed guidance can be obtained for specific activities. So the framework of approach is based on the common phases that OAT programs go through over time, starting with groundwork, moving on to more detailed planning, startup, rollout, and moving towards sustainability. And we know that OAT programs have got some core components that are applicable in most, if not all, of these phases, which include engaging with people with opioid dependence, interventions that focus with leadership and support, components related to financing, access to medications, workforce development and strategic information, and also components of service delivery. The training program is being developed as a virtual training with the potential for use in other formats. It is based on the tool, and it involves a package that includes a set of PowerPoint presentations, trainer's manual, and teaching materials that include videos. The intention is to have an interactive session that is participatory in nature. It's developed as two-hour online sessions. It involves a little bit of didactic information. There is a series of short videos that provide real-life stories in different contexts of OAT programs. There are interactive elements that include quizzes, discussions based on case studies, really drawing from local knowledge and trying to reflect geographical and experiential diversity. And then there's a summary of a recap of information. We're in the process of pulling together video examples from people with lived and living experience of OAT, as well as civil society organizations that either deliver OAT or support people on OAT, as well as from some clinicians and OAT experts. And we've got videos that have been provided either in English or provided with subtitles in English, which can also be used in other languages, from Kenya, from Nepal, from Morocco, Iran, Vietnam, and a few others that are in the pipeline. So the next steps include the finalization of the materials. There will be some tailoring of the trainings for countries that are about to start OAT programs. This will be followed by some regional trainings in UNODC regions, and then one training of the trainer session. Over time, the materials will be translated to languages for use in UNODC high country priority areas. So thank you to all the people involved. There's a steering group from UNODC and WHO, and also
Shall we start? So, hi, can you hear me? Okay, so maybe I can invite the members, the speakers to the podium to join me because it's a little bit lonely here. No. Thank you. Much better like this. So thank you very much for joining us. It's hard to compete with lunch and even harder to start after lunch. So really thank you for being here. So this session will talk about how to design tailored and prioritize HIV and hepatitis interventions for people who use drugs. So we have 4 speakers. Judy will talk about the perspective from the community, what is needed, how can we improve what we have in order to scale up access. Professor Amrad Al-Zahabi will talk about Egypt experience because Egypt made huge changes recently. Needle and syringe programs are now available also in the civil society settings. And the biggest step forward is the start of the opioid agonist therapy that will happen in a few days, actually. Patients will start receiving the treatment. And then my colleague Nicholas will talk about a recent guidance from World Health Organization, the consolidated guidelines that was updated. It was a collective effort. And then I have the pleasure to talk about our newest guidance, an implementing tool on how to start OAT program and how to scale them up in order to support countries that are preparing now to start or are interested in scaling up. So not to waste more time, I would like to invite Judy Chang, the Executive Director of International Network of People Who Use Drugs, to talk about community perspective on access to harm reduction, from coercive care to an ethics of care.
Thanks, Monica, for inviting me to the session, and thank you everyone for joining after lunch. So pleased to be part of this session. Just as a bit of background, the International Network of People Who Use Drugs is a global peer-based network representing people who use drugs, and our goal is to protect the health and defend the rights of our community. So for the next few minutes, I'll be providing a community perspective and opinion on harm reduction, both from my own personal experience as a client of harm reduction services for 15 years across different settings, Australia, Hong Kong, and Italy, but also, of course, as an advocate for harm reduction services. So we are 40 years into the HIV response. So this is 40 years after we have had undisputed evidence that harm reduction interventions prevent HIV and hepatitis C. But we are nowhere near where we should be. And of course, there are multitude barriers and the multitude of problems and reasons that explain this lack of progress. But they really can be distilled down into, the key issues of stigma, criminalization, lack of funding, and political will. So in this slide, I'll go through some of the key core harm reduction interventions, but of course they are broader than what I focus on here. Generally, harm reduction services are a range of services that enable people to safely consume drugs in contexts and settings that should be, and this is key, should be non-punitive, person-centered, and rights-respecting. And of course, it also includes safe supply, drug consumption rooms, and drug testing. But here I focus mainly on needle syringe programs, opiate agonist treatment, and naloxone, which are gold standard interventions for preventing HIV, hepatitis, and mortality. So I'm sure many people have heard the statistic that only 1% of people who inject drugs live in areas with high coverage of these interventions. And I think because we've heard it so often, we often forget how staggering, this figure really is. In looking at it, of course, it's no surprise that we haven't made enough progress. Here are some data from the global state of harm reduction. There are only 87 countries that have needle syringe programs available at all. Only 86 offer evidence-based drug treatment, and only 16 countries allow for peer-delivered and enable peer-delivered naloxone, all whilst we are in the middle of an overdose epidemic. But there is barely any outcry, any public outcry, and governments both casually as well as proactively deny us the minimum services we need to keep us alive. Instead, what little money there is available is siphoned off to inappropriate health services that care more about abstinence and are ready to coerce or violently sometimes enforce abstinence. And we know that these interventions don't work for preventing HIV and viral hepatitis, mortality, nor, of course, fundamentally respect human rights. But unfortunately, what we see is also this mission creep in harm reduction services, and I think it's really not called out strongly enough. There is an underlying assumption that we as people who use drugs should be grateful to have any services at all. But when services, what's really important is that when services aren't appropriate or tailored, people simply won't use them. Harm reduction interventions, where they do exist, are often shaped and undermined by, these social control imperatives, and are designed in ways that are, disruptive to people's lives and not amenable and understanding to, all the different responsibilities that people have in their lives. So if we look at some examples, needle syringe programs in some contexts require strict one-for-one exchange. They require registration, which definitely turns people away. Or is not attractive to people, arrest and harass people carrying needles and syringes, or only make them available in restricted or out-of-the-way areas. Opiate agonist treatment, primarily methadone and buprenorphine that is available, are designed and delivered in ways that make life as difficult as possible for people who use drugs. And, really often try and force people who use drugs into submission or act in certain ways and use, methods of humiliation and punishment for supposed infractions. We know that clinics, often refuse takeaways, especially from the very beginning. You're required to jump through all these hoops and therefore make daily attendance mandatory, when we know it's not necessary and we also know it's not possible for everyone. There are supervised urine tests. If you have a positive urine test, there is the risk of being thrown off the program. So really, they're supposed to be about care, but this care, can become coercive. And we see, these drug control rationales really bleeding into what should be, primarily and predominantly health practices and services. It is often presented as care. When I was first entered into treatment in Italy, I was told I had to attend fortnightly doctor meetings, fortnightly social worker meetings, fortnightly psychologist meetings, or risk disruption of treatment. There was compulsory urine tests that lead to hair tests that, lead to basically interrogations about, sometimes even alcohol use. I don't think it's exaggeration to say that going into these programs, you really don't feel like your body is no longer your own. I think this is why so many people who use drugs, choose not to enter treatment even when they are available. Naloxone widely, globally, it can be, unavailable, though even when it is, it's not always easy to access and not in the hands of peers that are most likely to witness and reverse an overdose. So therefore, we really need to be looking at not only a fundamental shift in practice, but also in thinking and approach. We need to disrupt, the totalizing logic that conflates drug use and harms. Because it is this principal logic that underlines modern drug policies and unfortunately also harm reduction services. And without really, being willing to challenge this idea, we will never really get to really committing to reshape the design, focus, and, understand the prioritization of services. So instead, if we look at different, approaches, coercive and conditional care can be replaced with a feminist care ethics, that sees care not as just top-down, but relational, and that really registers and responds to people's drug use in ways that sustain and improve ways of being. This also means recognizing that drug use, can be beneficial in people's lives and performs a function in people's lives and in their communities and in their relationships. And you can't just simply take that away without expecting, a negative impact. Programs have to commit to understand and meet service user needs, rather than imposing what the provider wants or thinks is a good idea. So a participatory harm reduction practice, really means becoming more responsive to the ways that people not only reduce harms, but consume drugs in ways that contribute to living better. So last slide, just looking at recommendations for moving towards focused, tailored, and prioritized services. One, global normative and technical guidance is key, and it is needed to guide harm reduction programs. And we know that these guidelines are best when they're shaped by community input. So input were involved in the recent revision, the 2021 revision of the WHO Consolidated Guidelines on Key Populations, as well as the UNODC and WHO OAT operational tool. And it's really important that both these tools are rolled out. Of course, secondly, meaningful involvement is critical, not only during the development of guidelines, but in the implementation, monitoring, and evaluation stages. It's people who use drugs who need to be involved in the priority setting, the design and delivery of service, and the design and delivery of services, because our involvement means that more suitable commodities that are acceptable can reach other peers as well, using peer outreach workers. It also means better quality of service delivery, because community involvement, increases the accountability and the transparency of the services to its clients. We really need to, look at how do we right the wrongs of drug treatment. People need to be consulted and listened to, and we can't always, believe this idea that the expert always knows best. I think there's just been too many examples of commodities and interventions that are being pushed on people, sometimes well-intentioned, but pushing it on people, never works out. And a really successful program is not possible without people who use drugs, because you need people who use drugs to voluntarily enter the services and, want to stay there. And that really takes, building trust and not treating people like children. I think COVID really showed what was possible when there was political will to adapt, and that services really can be designed to meet people where they're at. They can be flexible, they can be person-centered, if we only really look at the deeply entrenched prejudice that these services, are often built upon. They are health services. People who use drugs, we shouldn't be surveilled, controlled, or constantly supervised. We always associate those words with law enforcement responses, but, unfortunately, equally, they're often described on how people who use drugs are treated within health services and by health professionals. So I think just as we talk about drug policy reform, we really need to also be talking about harm reduction reform. Thank you.
Thank you. I think we have a minute or two for questions. So if there are any questions that you want to ask, Judy, you can. If you want to ask now, or if not, we can leave the questions for the end. Three more seconds to ask a question if you have one. Now. Okay, good. So then we move to our next speaker, and we'll hear about the road that Egypt took to start opioid agonist therapy. And we'll have the pleasure to hear from Professor Ahmad Al-Zahabi, the head of the scientific committee and professor in the Faculty of Medicine in Cairo, Egypt. Thank you.
Thank you, Monica, for giving the chance to present the harm reduction program in Egypt. As you all know, HIV, viral hepatitis, and sexually transmitted infections are a major public health threats worldwide, and it accounts for 2.3 million mortalities every year. 1.2 million people develop cancer each year due to viral hepatitis and sexually transmitted infections and HIV. Among the whole number of HIV patients, who is around 38 million, more than half of them are females. And 1.5 million adults and children, new cases are added every year to the HIV club. And so every day there is 4,000 new infected cases in the statistics of 2021. Every week we have around 5,000 young women aged 15 to 24 years old became infected with HIV. The mortality in the 2021 was 650,000 adults and children. And I wonder how the WHO wants to eliminate the HIV by year 2030, since we are adding every year around 800,000 or more newly infected patients. The risk of acquiring HIV is 35 times among people who inject drugs, 30 times higher for sex workers, and 28 times higher among gay men and other men who have sex with men, 14 times higher for transgender women. People who are injecting drugs, according to statistics of 2020, is around 284 million people aged from 15 to 64 years old. This corresponding to approximately 1 in each 18 people in that age group, and represents a 26% increase from the 2010. 36 million suffer from drug use disorders, and 1/3 of them are females. Young people, the age is 15, 16-year-old, continue to use more drugs than adults and have higher levels of use than in the past generations. In the year 2020, an estimated of maybe 500,000 deaths due to drug use. The problem is big. In the Middle East and North Africa, this region has the lowest HIV burden in the world. It had only 200,000 people living with HIV at the end of 2021, and 14,000 adults and children newly infected. But in this region, HIV is increasing by 33% from year 2010 to 2021. making it one of the 3 regions in the world where HIV is still on the rise. It also has the lowest HIV treatment coverage, which is reaching about only 50%. And the lowest proportion of people living with HIV who are very virally suppressed in only 44%. It is the only region where the children infection have failed to decrease since 2010. What about the situation in Egypt? We had the first case of HIV discovered at 1986, and since that we adopted the National AIDS Program for treating and for, caring of HIV patients. Egypt is estimated to have an HIV prevalence of less than 0.02%, and this is one of the countries with low prevalence rate. But HIV is concentrated at the key risk groups, people who inject drugs, and MSM at 2010 statistics. The UNAIDS estimated that the estimate number could be 30,000 people might be living with HIV, but the recorded MOH recorded cases is around 20,000 only. So the new cases are on the rise in Egypt, and it will be clear in this figure. You see this green line? At 2008, the number of HIV discovered cases was about 370 cases, increasing year by year until the year 2019. The discovered cases are 2,740. This means the cases are multiplied by 7 or 8 times from the year 2008 until the 2019. The most age group affected is the group of between the 25 to 34 years old, and this comprises about 45% of the cases. People who are injecting drugs in Egypt is around 94,000 people, and only 3% of the injecting drug users have access to the condom, and only 31% reported clean needle use at their last injection, as by the UNAIDS data book. Thanks to WHO, UNODC, and UNAIDS for adopting that comprehensive package of interventions for people who are injecting drugs in Egypt. In fact, I'm grateful, and we are in Egypt grateful to all these 3 societies or associations who are helping us regarding the prevention and treatment program. The main pillars are the needle and syringe programs, the opioid substitution therapy, and HIV testing and counseling, and antiretroviral treatment. And by the way, we are giving the up-to-date regimens of treatment for HIV, including the integrase inhibitors plus nucleotide reverse transcriptase. According to the most updated regimens of drugs worldwide. And we are giving it for free for all patients through the MOH centers for treating HIV. The prevention and treatment of sexually transmitted diseases, the program of condom use, the targeted information and education for either the common general population or even for the doctors and physicians who are not aware enough about the problem. We are adopting the vaccination program, and in this year we vaccinated all the patients for HIV, for hepatitis B, and and influenza vaccine as well, and we are now planning to give them the pneumococcal vaccine and the human papilloma virus vaccination. The same policy as well has been started in the prisons. In fact, prisons are very risky for spreading infection of HIV infection. So this is 15 key interventions for prisons with the help of UNODC and WHO, UNAIDS, UNDP, and ILO. In fact, they helped us also, and now we are adopting that policy or prevention policy in the 10 prisons, hoping to cover all the prisons next year. Needles and syringe program, it started in 2015, and by the year of 2020, we launched the national needle and syringe program through a signed protocol between MOH and some non-governmental organizations who are working in HIV field. MOH provides syringes to NGOs to be distributed through their outreach teams. In year 2021, the program scaled from 3 to 8 governorates through 11 NGOs, and we are planning to cover all the 28 governorates, inshallah, next year. The reached distribution is 270 syringes per each people who inject drugs in these governorates. Opioid agonist therapy, we started the ministerial decree stating that enrollment of opioid agonist therapy as a harm reduction, intervention, and addiction treatment approach. And by this year also, last year, I mean, a ministerial decree for the National Harm Reduction and OIT Committee formation, including governmental, academic, and UN authorizations. The last year, in fact, we started to train most of the healthcare givers for the new program of opioid agonist therapy, and it was carried out study tour by the UNODC, in fact, finalized national opioid agonist therapy guidelines. It was finalized, and inshallah, we hope by November 2022, we'll conduct the TOT train of trainers on provision of opioid agonist therapy through UN partners, in particular UNODC. And thank you.
Thank you very much. We have 1 or 2 minutes for questions now, if you have. If not, of course, we can ask all the questions at the end. Looks like there is no appetite for questions in this room. So then we'll move to, thank you very much, Professor, for the presentation. We'll move to our next speaker, Nicholas Luhmann, who is the technical officer in the Global HIV and Hepatitis and Sexual Transmitted Infections in WHO. Just to give a little bit of background, we as UN agencies are providing technical support for the scale-up of harm reduction programs in the countries, and we are also preparing technical guidance, normative guidance on how to implement these initiatives. So Nicholas will talk now about the consolidated guidelines on HIV, viral hepatitis, STI prevention, diagnosis and treatment, and care for key populations. Thank you.
Thanks, Monica. Hello, everyone. Like Monica, I wanted to thank you to come during lunchtime. You're still a little bit shy, but maybe we'll get some questions towards the end. So as you said, Monica, I will present the new, very recently published consolidated key population guidelines to which UNODC has given as well a lot of input. And there are one of the main documents, if not the main document at WHO, where the questions of drug user health and prison health are addressed. There's as well more specific OAT guidelines and other guidelines, obviously, that refer to the topic of key populations and more specifically people who use drugs. I think as well, maybe just to mention that Egypt is a very good example where WHO and UNODC and the MOH and many other colleagues work together to achieve together what we've just seen from the colleagues from Egypt in this conference. So a very quick background. This one is our new global health sector strategy. I won't present it in detail, but as a background, because you will see it's echoed somehow in the key population guidelines, the new strategy from WHO is now an integrated strategy for HIV, viral hepatitis, and STIs, goes to 2030. The only point I wanted to make here, it has a really much more stronger accent on integration, person-centered care, and really highlights opportunities of where person-centered care could make an even bigger difference to people's life. And that includes very explicitly the topics that we mainly discuss in this conference, such as prison health, drug user health. Very quickly, just a background, and this is not only data on drug users. I thought it was, or prisons, was interesting to show a little bit quickly one or two other data points. The one on the left upper part is a histogram of pooled syphilis prevalence in MSM, and that was just to show that, for example, syphilis in MSM is stable over this time frame. This is 2000 to 2023, or 2 decades, and really not much reduction globally and high incidence rate in this population. Below is the hep C prevalence rate in this population from a systematic review that we did with colleagues from Australia, and shows quite high hepatitis C prevalence rates in MSM, especially if they're HIV positive. And on the right, that is HIV data that shows the distribution of new infections globally, incidence of HIV across the world. And you see that 70% now of all new HIV infections are estimated to be among key populations. Another topic that I just wanted to show here, focusing in on some data points from the Southeast Asian region, is that actually, and this is quite well highlighted in this as well, and maybe quite often forgotten, is that young people are very important to the response. Here we can see that 26 of new HIV infections in Southeast Asia are in young people, and that 99% of all of those are in young key populations. And another example would have been, there was a presentation from Peter Wickerman on Myanmar data that showed as well that the incidence for HIV and hep C, I believe, in a very long cohort in the north of Myanmar, showed much higher in the younger people or recent injecting drug users, for example. So the guidelines, I mean, it's a complex document. I'm not going to present them in remaining 6 minutes, but maybe just to highlight a couple of things. So the first thing I said already, mirroring the global health sector strategy, they have a very strong person-centered focus. They insist on integration and person-centered care. The second thing is this kind of graph, which shows a sort of theory of change, or I don't know. And the point I wanted to make here, which I guess as well refers partially to Judy's presentation, is really that the response that will lead to a change in mortality incidence, health of key populations, is really the combination of combining structural work around stigma and discrimination, criminalization and inequalities with community empowerment, quality and evidence-based health services, and adapted service delivery approaches such as decentralization or integration and involvement of peer workers. So again, this is actually one of the pieces that are not new, but what is new, I believe, they are very much highlighted in all chapters, is that the backbone of interventions in key populations are really the enabling interventions, as they're called in the framework of this document. And you can go to the document and you will see there are actually formal recommendations from WHO in these 4 areas to reduce stigma, empower community, addressing violence, and removing or adapting the laws that surround not only drug use, but as well what concerns other key populations. And then there are the service packages. They are now really very integrated. It's not only an HIV guidance anymore, and so that goes across prevention, diagnosis, and treatment. And you can see here highlighting all the main areas that are important to address those 3 disease areas. Then there is as well a suggestion for additional health interventions for addressing broader health problems in key populations that some stakeholders and implementers found very interesting and helpful that this was integrated. It goes across different areas. They are very related to HIV, viral hepatitis, and STIs, but they're not specifically having an impact on those areas. So this includes animal health, other reproductive health services, addressing alcohol use, and mental health. So in terms of service delivery, there's a whole chapter that lays out the main pieces of differentiated service delivery, and there's a few new recommendations. One is around virtual interventions. We don't have the time to go in detail of this slide, but it's just to show that there's about 4.8 billion people now that use the internet, and there's a huge amount of activity on social media. And so virtual interventions for prevention, but as well testing and treatment related ones, become really much more forefront. And so we have now formulated first time a recommendation, formal WHO recommendation based in a systematic review, evidence review for online delivery of services to key populations for those disease areas, highlighting the importance of data security and confidentiality, because the key populations network, such as Input with Judy, who worked with us, really highlighted that in the guidelines development group. The other service delivery recommendation that is new, that means it's not the only service delivery recommendations, but embedded in the larger aspects of service delivery, is around peer navigators, and recommends formally to work with peer navigators to support people from key populations to start treatment and to remain in care. There are 2 additional viral hepatitis recommendations that are additional to all the other standing recommendations for how to treat, how to test for viral hepatitis C, treat hepatitis C, and what are the service delivery approaches in this area. And just very quickly, they've really been developed in view of providing continued care and having an impact as well on incidence for hepatitis C for people at ongoing risk. So we recommend now that service providers consider retesting for the presence of viremia, for example, in people who have undergone cure, and to continue to provide care. And we've seen actually in the INHSU films that many programs start to do that now. And the other one that is specific to this is for people with ongoing risk to offer DAA treatment immediately, or at least discuss that, so offer to the patient immediate treatment and not for recently acquired infection, as hepatitis C sometimes clears, as you know, spontaneously. Some providers and as well insurance companies think that it's a way to wait for that, but we recommend immediate treatment at least as an offer to the patient. So there's additional best practice statements. I don't really have the time to go into detail, but there's one on chemsex. There was not enough evidence to recommend very specific interventions, but there's an overall new best practice statement, which doesn't mean it's a strong recommendation. It's just not enough evidence to make it really WHO recommendation as the norms stand. And there's one for chemsex and one new one for behavioral interventions, which is quite interesting because we found that counseling behavioral interventions did not have at least a direct impact on incidents or risk behaviors. So we do not say that behavioral interventions can't play a role, but they should not be maybe, let's say, over-interpreted as a very impactful standalone intervention. So that is just to acknowledge the big team on behalf of whom I'm talking, the key populations team and prevention team at the WHO headquarters.
Thank you, Niklas. Again, if there are any questions now or so we have some questions for Judy and about Egypt, but we will keep these questions at the end. So now I'm going to change the hats because, you know, we are multitasking. So I'm not going to be the chair anymore. I'm going to be the presenter. So I move over there. And I just realized that at the beginning I forgot to introduce myself. So my name is Monica Chupaja, and I'm the focal point for drug use and HIV in the HIV program of the United Nations Office on Drugs and Crime. And I will talk about the newest guidance. Actually, the photo that you see on the screen, I received yesterday. So it's really, really fresh from the oven, and very soon the publication will be available on our website, and it's an operational tool for low and middle income countries who are starting or scaling up opioid agonist therapy. So, you know, why did we work together with our colleagues at WHO to do this publication? Is because you know, opioid dependence contributes to a lot to the morbidity and mortality. The use of contaminated drug injecting equipment contributes to the spread of HIV and hepatitis C among people who inject drugs. Actually, as you probably know, half of the people who inject drugs are living with hepatitis C, and 1 in 8 with HIV. Opioid agonist therapy is effective treatment for opioid dependence and improves health and social outcomes, and we know this for many, many years. And of course, in this publication, we try to summarize other recommendations for guidelines and treatment standards and guidance for the integration with HIV programs. So why did we thought it's a good idea to do this publication? Well, because even despite all the evidence and despite of many years of implementing opioid agonist therapy, the coverage is low. Actually, you will hear more about the coverage in the next session in this room, so I encourage you to stay. What I have here is the data from 2016-17. Coverage remains low. Only 20 countries have more than 40% coverage with OAT. And we have a new global AIDS strategy that recommends that in order to be effective in the HIV prevention, the coverage should be 50%. The intention of this guide is to support professionals to establish and deliver evidence-based OAT services. Also to provide practical guidance in the process to start, roll out, and improve program quality. Also to focus on OAT services in the context of drug-related HIV, hepatitis B, hepatitis C service delivery in community settings. You know, another recommendation from in the global AIDS strategy, not a recommendation, it's a target, that is the 80-60, what we call 80-60-30 targets, meaning that 80% of the prevention services should be delivered by community-led organization. 30% of the testing and treatment should also be delivered by community-led organization, and 60% of the advocacy work. What this guide is not a clinical guideline and does not include details of OAT provision in prisons or in closed setting. We thought it will be too much to cover everything in one guide. The targets for the target population audience for this tool is the health policymakers, the healthcare providers, and the health managers. So what was the development process? Well, we had a working group that include, as Judy mentioned earlier, colleagues from Input, but also from regional drug user networks, from harm reduction groups, as well as our colleagues from UN. As I said, we developed this guide in collaboration with WHO, but also colleagues from UNAIDS and UNFPA and UNDP provided their comments. We did a desk review. We looked for case studies, in particular in UNODC high priority countries, because we know them best. We did data synthesis and also the review and the peer review to finalize the tool. And again, the cover, because I'm so proud of it. So the structure of the tool, we have an introduction, we have a framework that is defining what is OAT and all the names that we have now for OAT, because my generation used to say opioid substitution therapy, but then it was methadone maintenance therapy, medical assisted therapy, opioid agonist therapy, and now we have opioid agonist maintenance therapy, WHO wording. I'll say, this is my personal, and I might take the liberty to make a joke, but since we diversified the names, we saw that, the more and more countries adhere to treatment. So I think it works, to have so many names. And then the treatment the access to treatment is increasing. Then in the chapter, from the chapter 3 to chapter 6, there is a lot of information about how to lay the groundwork for OAT services, how to plan to implement these services, how to start, how to roll out. Chapter 7 talks about increasing the sustainability, and the last chapter is looking at the specific populations. We have case studies, as I mentioned, from countries where we work, from Kenya, from Vietnam, from Morocco, Nepal, and also in our training package that I'm going to show in a minute, we have personal testimonies of people who are accessing the services and what is their personal feedback. The how-to sections focus on the most important interventions during each phase. So for each OAT program phase, we have the time, the groundwork, the planning, the startup, the rollout, the sustainability. And then we are talking about the main OAT program components, like engaging people with opioid dependence. We're talking about leadership and support, financing, medication, workforce, and strategic information, and of course about service delivery that is done, with respect to people rights and their will to access the services. As I mentioned, we prepared the training program to support the rollout of the publication. Actually, pretty soon we will have, in 2 weeks from now, we will be in Cairo to have a face-to-face training, and we are all very happy that we have this opportunity. We can also deliver virtual trainings, and we have PowerPoint presentations, trainer manual, teaching materials, and participatory methods. The training takes 2 days. The virtual one is 2.5-hour session. The face-to-face training, it's a 2 full days training. As I said, there are short recorded videos. You can see some of the people that offer their testimonies on the client's perception, on the service providers, on the health managers, on how they manage to put in place successful programs. Of course, what are the next steps is to translate the tool and the trainings in as many languages as possible, especially in the UNODC 24 high priority countries, and to continue delivering this and improving the training and the tool. And here you have a long list of people who contributed to the tool and to the training materials. And that's it. Thank you. So now I'm resuming my chair duty. So so maybe Judy, you can answer the first questions that are here on the screen. Maybe we can go back to the first, yes. From Daniel C.
Maybe we need
Yes.
to read it out.
Okay.
So, do we need to rethink the use of cash incentives in harm reduction programs? Are they a valid way of supporting people to use services or just another form of coercion?
I mean, I think, again, it's a matter of consulting with the people that are using those services, right? I haven't heard of cash incentives being used within harm reduction programs that much, so it'd be great to hear of some examples. I know it's used in hepatitis C treatment programs, but yes, I think it would take consulting with, the local community there.
Okay. The questions are moving quite fast, so it's, maybe that's a question for Nicholas. How do the new virtual intervention consider people who use drugs who are digitally deprived due to lack of access or literacy or etc.? How can we see there isn't any further marginalization within groups?
Fantastic question. I will start the answer. Judy, if you want to add something, because you've all been entirely part of that process, and I think have maybe even a stronger sense of what it means on the ground. I mean, I think that's what I tried to say. Two things. The virtual interventions recommendation is really kind of an additional recommendation in the sense it could be only used in populations which use mobile phones or other digital devices to be potential clients of those. And so we are recognizing that there are data security issues, and there's as well many people who don't have that access. And so it should never be an exclusive way to try to reach people or support people, but it can be helpful in in some groups that have that access. Secondly, I would like to say that really the biggest part of the evidence, and this guidelines is not only focusing on people who inject drugs, the biggest evidence of virtual interventions today in terms of key populations is with men who have sex with men, and that's where it's a lot used in Asia, for example, and where really the practice and the evidence is largely coming from, and where there's now a lot of experience emerging. I think that the experience with people who inject drugs are less, and maybe there are other challenges. Maybe, Judy, do you want to add anything?
No, in terms of the digital interventions, yes, I think you captured it quite well. And when we're involved in the consultation, a lot of the community representatives, wanted to strongly emphasize that it shouldn't replace, face-to-face interventions, and it should be in addition to and offer people more choice rather than like taking, face-to-face away, which, beyond the digital divide, I think some people may also, prefer that contact as well.
Thank you. We have a question about Egypt. The question is if the increase in cases seen in Egypt in the recent year is a consequence of increased incident or a result in making the testing more available?
Yeah, this is a very good question. In fact, of course, 15 years back or 10 years back, we haven't that more of the screening tests for the HIV. But now it is routine for every patient who is going for any surgical intervention. He should be screened for both hepatitis C, B, and HIV. Now every pregnant mother are screened for HIV. So always students in the university and the people who are going to the military service, all these people are screened now for HIV. So we enlarged the screening tools for discovering new cases. This is a good factor. But in fact, people who are taking injections, especially in the youth age stages, is also increasing. So the both answers could be right. But in fact, we are doing more screening tests, so we discovered more cases. And what we are discovering is, not the real number, because some people are escaping from that, screening areas. So UNAIDS estimated that 30,000 are infected, while the real statistics in the MOH is around 19 or 20,000 only. So the challenge is how to pick up these cases, because they are going here and there, practicing many things, sexual relations, or going to the dentist or any hospital, and he is not, we don't know that he is infected, and he might give infection to others. According to statistics, not Egyptian, worldwide statistics, every HIV patient, if he is not discovered, not put on a program of treatment, he could infect 3 of the population, 3 to 4 persons from the population. So the situation is serious and needs more and more efforts to pick up these cases.
Thank you.
Welcome.
I got the message that we need to wrap up, but just we have one more question, and I think all of us can contribute to this question. Is what was the method for estimating the proportion of population engaged in drug use? So you may know that United Nations Office on Drugs and Crime is publishing every year the World Drug Report. And there you will find data about the proportion of general population using drugs. And then, of course, these are estimates, and the number of people who are estimated to inject drugs, and the prevalence of HIV and hepatitis. And how we collect this data for the World Drug Report is that we collect the data from the government structures. But once we have the data, especially on injecting drug use and the prevalence of HIV and hepatitis, we go to our colleagues at UNAIDS and WHO and Harm Reduction International and compare the data that we have with the data that they have and try to make sure that what we publish is the most accurate estimation. Of course, you can imagine that being an activity that is not legal in any country or in many countries, it's very hard to get the exact number of people using, exact number of people injecting. So these are estimates based on, as I said, in the World Drug Report, you will find the data that is generated from the reports that we receive from the government structures, compared and combined with the data from UNAIDS, WHO, Harm Reduction International. But I think this question will be discussed in the next session at length, because you will hear from about the newest estimation and how this data was collected. So I don't know, maybe Nicholas, would you like to say something about WHO or data? No. Judy?
No, wouldn't add anything.
Okay. So thank you very much for your attention and for asking these wonderful questions and very stimulating ones. So we'll take a break and we'll come back to the next session.